Hello, everyone. Oh, there we go. Good afternoon, everyone. In about 5 minutes, we're going to get started with our next panel, which we're very excited about. You're free to stay where you're sitting or rearrange however you prefer. Thanks.
Yeah. So,
close box. One of the boxes. Yeah, just put them down. No, like yellow, so that you can see them there. And then do the last one first, and then open it up. Yeah. Holly and Anandra last. Yeah. Okay. And then Tim. Yeah, just close one of them so it's not. Yeah. Is there any? No. Okay, I think we're good. Maybe we'll tell Mickey too. I think it's like
Hello, everyone. We are so excited to get started for our afternoon, if you can make your way to your seat. Hopefully, all of you that are in the afternoon poster session have gotten set up for that. All right, good afternoon. I'm going to introduce our panel that is going to start focused on research that's been sponsored by the USD Prescribing Research Network. If you all could find your way to your seats, we'd be appreciative. There will be more time for conversation during the next poster session and when we wrap up at 4:30. I can't get them to quiet down. Oh, here we go. Okay, good. Oh, yeah, here we go.
Okay, we're going to get started to stay on track and finish on time today. Right there, Dr. Boyd? Yeah.
Great. All right. It is, before I have the pleasure of introducing Nikki Brandt, who you just heard from, I just have two announcements. One is make sure you get your posters up for session 2. Which will be a little bit later this afternoon, and there'll be more time for interaction and conversation then. And the second thing is don't lose your raffle tickets. You have to be present at 4:15 for the raffle drawing to win some of our amazing swag, which we're very excited about, Mike and I and our whole team. All right, so now it's my great pleasure to introduce Nikki Brandt, who is a professor in the Department of Pharmacy Practice and Science and executive director of the Peter Lammy Center on Drug Therapy and Aging at University of Maryland School of Pharmacy. Dr. Brandt is co-leader of the USD Prescribing Research Network Stakeholder Engagement Core, and she's going to introduce our panel.
All right, well, good afternoon. Good for everybody, I think it's good afternoon. From us East Coasters, it's almost good evening. So welcome. It's a real honor and privilege to be moderating this conversation. And it's been fascinating over the years working with our various stakeholders, our investigators, our researchers to see the progression of the work that they've been doing. So the way that this is going to be navigated, both for our panelists as well as for all of you. They'll spend about 5 minutes presenting their research. We'll take 5 minutes for Q&A, and then at the very end, we'll have the panel come together and we'll have some general conversation about some of the research efforts as part of the USD Prescribing Research Network. I just want to do a very warm thank you to our stakeholder council members who were able to make it today. So with that, I just want to say a shout out. I don't know if they're still here, but Susie, who you saw as part of the panel, Rosario, who is also with us, Sandra, I'm not sure if they're still present, and of course my co-partner, Catherine Sarkeesian, in terms of the work with the stakeholder engagement group. So let me introduce our research presenters today, and so very excited. Our first presenter will be Dr. Timothy Anderson. Some of you may be familiar with Dr. Anderson's work. He's going to be focusing on clinician and patient perspectives on prescribing and deprescribing opioids for chronic pain. Super excited to know a little bit about Dr. Anderson. He's coming from Beth Israel Deaconess Medical Center. We were worried you weren't going to make it. We know there was a bit of a delay. He is a clinician investigator in the Division of General Medicine and assistant professor of medicine at Harvard Medical School. He's been a member of the USD Prescribing Research Network's second junior investigator intensive cohort. For any of you interested in that, please talk to Dr. Anderson as well as any of us. And he's a USD Prescribing Network Pilot Awardee. After Dr. Anderson, we will be having the next order is Dr. Lauren Hunt. Very excited to hear about Dr. Hunt's work. Dr. Hunt has been doing focused work as a nurse and researcher as an assistant professor in the School of Nursing at the University of California here in San Francisco. And Dr. Hunt is also a USD Prescribing Network Pilot Awardee. After that presentation, we will have Dr. Min-Yi Kwok, and she's coming from the University of Texas. We have a big Texas constituency. I see how you gathered down at the end of this table. Is there any sort of noise that's supposed to be made? Woo-hoo. So with that being noted, so we're going to keep you awake after lunch if you haven't figured that out. Dr. Min-Yi Kwok is an assistant professor of the Division of Geriatric and Palliative Medicine at McGovern Medical School at the University of Texas Health Science Center at Houston, and Dr. Kwok is a USD Prescribing Network Pilot Awardee. And to the left of her is her mentor, Dr. Holly Holmes. You guys are up the same panel together. Dr. Holmes is no stranger to many of us in the field of deprescribing. She's a professor of geriatrics and director of the Joan and Stanford Alexander Division of Geriatric and Palliative Medicine at, again, the same school, McGovern Medical School at UT Health Houston, as well as an attending physician in geriatrics. She's super uber busy, but super excited to say she's been a major member of our USD Prescribing Research Network, and she did get an award with her colleague, whom I'll introduce in just a second, the USD Prescribing Network ADRD supplement in conjunction with Dr. Nayak. So hopefully I'm gonna get this right. Dr. Anand Nayak is also at UT Health Houston. He is a geriatrician and chair of the Department of Management, Policy, and Community Health at UT Health Houston. What a powerhouse you have there, Dr. Holmes, as well as the executive director of the UT Health Consortium on Aging. And he also is very involved with the USD Prescribing Network ADRD supplement, and is going to talk about that with Dr. Holmes. So if you could take a moment and give us a warm welcome to all of our awardees and discussants today. And I'm going to turn over to Dr. Anderson.
Get it.
I think it's all set.
Oh, easy.
Yeah, there we go. Yeah.
All right, great. This may be rough because I'm a big data researcher and qualitative work is like totally out of my field, and I'm on East Coast time and flew in this morning. So we'll give it a go in 5 minutes. We're going to talk about clinician and patient perspectives on prescribing and deprescribing opioids for chronic pain. So obviously a lot of media attention is focused on the opioid epidemic, particularly in the States, and we've largely thought, I'm a primary care doctor, that it feels like that media attention is really all around younger adults and risk of overdose. And there's this kind of discourse and CDC guidelines and all these different things that are kind of hyper accentuated on this idea that like we need to get people off opioids or they may overdose and badness will happen. Our team, which often includes clinicians who are interested in trying to support conversations about whether long-term meds are still right for patients, tries to use things like the deprescribing.org resources to help talk to people, looking at Barb, and notice that there wasn't a lot of resources out there about how to talk to older adults about opioids, and that in our heads, maybe some of the discourse out there was informed heavily by kind of the stigma and the whole discourse about the opioid epidemic. So we wanted to learn more about that. And really our goal was to think through, could we at some point build interventions or conversation aids or decision aids or other things to really help clinicians and older adults have conversations about long-term opioid use that might differ from what's out there in the CDC world, which is largely information about how to have conversations about overdose risks, which may not be quite so pertinent for this population. So funded by the USD Prescribing Research Network, we conducted a qualitative study focused on a convenient sample of older adults in Boston, as well as their practicing primary care docs in a large academic health system where I'm based. And these were all semi-structured interviews that were analyzed using inductive coding. And really we focused on understanding experiences managing chronic pain using opioids, both for adults and physicians, and experiences that physicians and patients had with reducing or deprescribing opioids, as well as their perspectives more broadly. Our study population was 18 clinicians from a Boston area health system. Despite being from one health system, they were relatively diverse when it comes to being clinical and community-based, and included a couple different specialties beyond primary care. And then 29 older adults who received long-term opioids, and we were happy to have a reasonably good representation of folks over the age of 75, of Black patients, and of folks using kind of differential types of opioids. That small table is really just to give you a sense of how much folks were relying on their opioids at baseline, which was PEG scores, for those who are familiar with pain management, is kind of a way to grade pain and its interactions with your life over the past 2 weeks. And so these patients were reporting fairly high pain and interference of pain with their life, while on the opioids, in really a view that their pain would be about as high as it can go if their opioids were stopped, just to give you a sense of where people were coming from. So I'm mostly going to talk about clinician perspectives because we finished the patient interviews last week, and so I can't analyze qualitative data quite that quickly. But I think the clinician experiences prescribing opioids for chronic pain will probably feel familiar to clinicians in the audience. Docs are uncomfortable with opioids. And I think this quote of "I'm pretty much always uncomfortable prescribing opioids for anyone, but more so with older adults" is really kind of illustrative, particularly of what we saw from junior doctors, even more so than senior doctors. But there was this acknowledgement of opioids as a last resort. That being said, clinicians said that when they prescribe opioids, it's really in an effort to balance risks with benefits for folks with increasing age and multimorbidity. And here, I think the emphasis that folks had was, well, in older adults, I can't prescribe all the stuff I might prescribe a 35-year-old, so sometimes I'm left with opioids as my only choice, and I want to help people achieve their functional goals. That's where physicians were sitting when it came to their perspectives, and I don't think that surprised us too much. When it came to physician views on de-prescribing opioids, we got a kind of more surprising bag. Basically, docs said this doesn't work. They said this is an important topic, it's something we really should be doing, but each time we try, we're rarely successful. And barriers to opioid prescribing, I think, were kind of all over the place, but I think the most illustrative I saw was it's really hard to tell someone I recommend that we cut back on a dose of this medication that you think is helping you, and I don't have anything to replace it with. And I would love if I could see patients every week to de-prescribe their opioids and say, how'd that go? But I can't see patients every week. I can see them every 3 months. So that means either we don't do it or we do a suboptimal job of it. And there was really this emphasis from both patients and physicians that successful de-prescribing is built on trust, and the current health system kind of undermines the ability to continue those trustful conversations. I want to at least provide a tiny bit of patient data since, I did just say I did a study that was mostly patients more than doctors. And so what I'll show you is we asked patients what sorts of topics would make them want to have a conversation about de-prescribing opioids with their clinicians. And here we really asked them a series of different topics that we know in the guidelines and just doctors in general may bring up. Some of them are symptom-related things, like if you were having a bad worsening memory or if you were falling, would that make you want to talk to your doctor about potentially reducing this medicine? Again, not stopping the medicine, but just having a conversation about it. And you can see for the first three, which are all symptom-based, patients were pretty responsive to this. These symptoms are things that they would want to have conversations about. On the other hand, when we brought up kind of more distal concerns, so simply getting older increases your risk with opioids, or what if you took too much, or what if your family had concerns, or what if the guidelines said that you were taking too many opioids, there was a much more mixed bag. There was a lot of, I know my body best, and these guidelines or these family members or whomever may not be the ones to make that decision. And tolerance of all things was probably the least popular kind of reason to have a conversation about opioid de-prescribing. As I said, we have a lot of, I think, interesting qualitative data coming from patients as well. And perhaps the most common, I think, interesting theme to share is that patients identify fear of overdose as their big concern with opioids, and doctors do not. Doctors say, I don't worry about overdose in my older adults. I worry about falls and memory and all these other things. And so we see this very large disconnect, I think, between patient and doctor fears, which may be something to work on in future work. And ultimately, our long-term goal is really to take this pilot and think about how can we build materials to help doctors and patients have better conversations about using opioids or stopping opioids if they're no longer kind of having the right risk-benefit profile. And so this is our team, all from Beth Israel, and I'd be happy to take questions. That felt fast.
Yeah, you did perfect, actually, 6 minutes. So yeah, that was awesome. Any questions for Dr. Anderson? I do. So, and then we'll ask from the audience as well. So I know you presented some of your work to our Stakeholder Engagement Council. They gave you some feedback on the survey. How did you increase diversity in your sample? I was impressed by the age as well as the 35% Black older Americans. So, yeah.
Yeah, great question. So in part, based on feedback from the stakeholder panel, we did oversample for 3 characteristics. One was minority patients. One was patients over the age of 75, which is certainly a small segment, at least in our clinic population, who are on chronic opioids. And the third one, which I didn't show in part because we were least successful, is folks who are on high levels of opioids. We tried to recruit those folks, and it was very hard. I think maybe 2 or 3 patients had daily oral morphine equivalent over 100. But it was really through, targeted sampling was my approach.
Any other questions from the, I have to be up to the mic. Any other questions from the audience? Okay. If not, we will have the panel questions at the end, and I think now Dr. Lauren Hunt, you're going to go next. Thank you. I think yours should come up next.
Hello, everyone. So I'm going to be talking about deprescribing of anti-dementia medications for hospice enrollees with dementia. So I think most people are aware that hospice is a model of care that focuses on promoting comfort and quality of life for individuals with a terminal illness. In the United States, since most decedents are 65 and older, hospice is generally paid for by the Medicare hospice benefit, which covers care for terminally ill Medicare beneficiaries. Something that many are not aware of is just how prevalent dementia has become among hospice enrollees. Our research shows that actually about half of all hospice enrollees have dementia, and this includes people who are admitted with dementia as their qualifying terminal illness, as well as those who are admitted for another condition, but who have dementia as a coexisting or comorbid condition. So admission to hospice is really an ideal time to revisit appropriate prescribing and weighing the costs and benefits of continuing preventative or maintenance medications such as anti-dementia medications. And in general, the existing guidelines such as Stop Frail guidelines favor deprescribing of anti-dementia medications among seriously ill people with dementia. But there's still some controversy, with concerns centering on withdrawal effects and reemergence of symptoms. Also, due to prognostic uncertainty, people with dementia tend to have long stays in hospice and are frequently disenrolled from hospice, and you can come to my talk on Friday at AGS to learn more about disenrollment. But this potentially alters the cost-benefit equation of continuing or discontinuing medications. Another concern in recent years among federal regulators is around high Part D spending among hospice enrollees. So when people enroll in hospice, the hospice agency is supposed to cover all medications indicated for that terminal illness and related conditions, and is really supposed to cover virtually all medications. But in recent years, Part D spending among hospice enrollees has skyrocketed by hundreds of millions of dollars a year. But we really know very little about current anti-dementia drug use and payment in hospice. So our objective with this study was to assess anti-dementia medication use among hospice enrollees with dementia and determine who was paying for those medications, whether it's Part D or the hospice agency. So to do this, we used a 100% Medicare sample and selected hospice enrollees who were admitted between July 1st, 2014 and June 1st, 2018. We selected this time period because this was a time when hospice agencies were required to report detailed medication prescribing to Medicare. We included people who were 66 and older with either an admitting or secondary diagnosis of dementia based on their ICD codes, and who had a hospice length of stay of longer than 30 days. They also needed continuous Part D in the 12 months prior to hospice admission. We defined baseline use as having a continuous 30-day supply of an anti-dementia medication, donepezil, rivastigmine, memantine, or galantamine in the 12 months prior to hospice admission. And we defined continued use as having a new prescription for an anti-dementia medication after hospice admission, either in the Part D or the hospice claims file. We use this because it's easier to assess continued use rather than if people stop using. So we found really surprisingly high use of anti-dementia medications, both before and after hospice admission. So 50% of people with dementia admitted to hospice were baseline users at the time of hospice admission. And of those, 50% of them continued using an anti-dementia drug after hospice admission. And we didn't really see differences between whether they were admitted for their dementia or they were admitted for another terminal condition, and also had a dementia diagnosis. We also found that Part D covered the vast majority of these prescriptions. About 85% of them were covered by Part D, and this was just a little bit higher among people who had a secondary dementia diagnosis compared to a primary. So in some, we really found high use of anti-dementia drugs both before and after hospice admission, really despite limited clinical benefit of these medications. And we found that Part D covered most of the medications for hospice enrollees, which really is probably concerning for Medicare as a payer of these medications. So we're really in the beginning stages of this analysis, and there's many more questions to answer. For next steps, we're going to be looking at patient predictors of continued use as well as hospice agency variation. And I think this data will form the preliminary foundation that we need to develop standards and guidelines for hospice deprescribing and payment of these anti-dementia medications. And I think have really important implications as the new anti-dementia medications such as aducanumab and lecanemab, which are both very expensive and much more invasive than existing medications, come on the market, and how we think about using and describing these medications for people in dementia and at end of life. And with that, I would like to acknowledge my co-authors and stakeholder committee and funders. And if you are a co-author in this room, please raise your hand. There's a few here. And I'll take any questions.
All right, thanks, Dr. Hunt. Any questions from the audience? Well, Dr. Hunt, I have one question then. So, outstanding work. And as a nurse on the deprescribing team, especially in hospice, what do you think are the next steps to engage other hospice care providers in this?
Yeah, that's a great question. We've actually been doing some interviews with hospice clinicians right now, and I've been asking them this question, and it's just so interesting how varied people's responses are to how much they're thinking about this. I think for most people, and I remember this for myself as a hospice nurse, that I didn't give these medications a whole lot of thought. If somebody wanted to stay on them, Part D was covering, and we just continued it. So I think there is a huge need for information especially amongst hospice nurses, who are really the ones who are leading the conversations with the patients about how to think about continuing with these medications or not.
Thank you. All right. Appreciate that very much, and we're staying right on track with the timing. Our next presenter is Dr. Min-Yi Kwok. Standing behind you. Thanks.
How do I start my slide?
Oh, sorry. Let me get there so we close this one up. Oh, that was not you? That was her slide. Sorry. Oh, yeah, there we go. And you're next. Thank you. I hate lurking behind. There we go. Thank you. Thank you.
Good afternoon, everyone. My name is Min-Ji Kwak. I'm one of the pilot grant awardee, and the topic of my study is the optimal intensity of heart failure medications for older adults. So my idea started from the fact that older adults with heart failure take too many medications. And as you can see on the screen, 2022 guideline for management of heart failure started with the take-home message that now we increase the medications, and now they started with 4 medications. And the clinicians struggle a lot between accepting appropriate polypharmacy, but also deal with medication-related problems that can happen for older adults with various geriatric syndromes, and that started my study. However, the guideline of the heart failure medication only gives very small information about the dosings, and it started with initial dose, and it also gives us target dose, and then they only recommend us to go to the target. But the target dose is most of the times are too high for the older adults, and they are not able to tolerate the high doses. So we practice in the gray area between the initial dose and target doses, and we don't have much information about whether the dose that I prescribe is considered high or low, and then whether we have to look for a side effect or whether we have to increase the dose of the medications. So that prompted my study with these 3 aims. The first aim was to do a scoping review study to define the intensity of heart failure medications to answer the question, how does the literature define intensity of heart failure medications? And the second aim was to conduct a retrospective cohort study using a Medicare data, answering the question, what percentage of older adults with heart failure actually received high or low intensity heart failure medications using the definition that I found from the aim 1. For the stakeholders' engagement, we accepted the fact that yes, we can create intensity, we can define the intensity with all the numbers. However, would it apply to our older adults? So we wanted to answer the questions, how would older adults define the intensity of heart failure medications in real life, and what aspects would they use to describe intensity? And for stakeholders' engagement for this pilot study, I would like to highlight that I got a lot of help from the community scientist program at UT Health and MD Anderson Cancer Center. At UT Health and MD Anderson Cancer Center, there is a community scientist program who has a lot of trained community members who specialize in advising researchers from layman's perspective. They review the researcher's proposal and then give us the feedback in layman's perspective, patient's perspective, and caregiver's perspective. And then they help us to enroll, to construct the enrollment plan, methodology, and questionnaire. So after I created a questionnaire for my interview study for stakeholders engagement, I got a lot of feedback from them to change the verbatim so that they can understand what I would like to assess from their perspective. So this is the result, and I know that this is only 5 minutes, but this is the showcase. I'm going to show what I did. So I started with 29,000 articles review, and then ended up getting 464 articles included. And then this is the result of the definition of high and low intensity for any medication that you can think of that you can use for heart failure. It's a very long table, so I'm not going to tell everything, but this is long. See, this is a showcase, so I'm showing off. So based on this definition, I went back to the Medicare data, 5% sample, 2015 Medicare fee-for-service beneficiary, and then I assessed the percentage of older adults who actually received low or high dose intensity for any heart failure medication classification, and I included 5 medication classification. As you can see in the gray area, a gray cell, less than 50% of older adults actually took high dose of medications. And then it's not target dose, it's a high dose, and then this high dose intensity was defined from the literature review. So we identified that very small percentage of older adults actually take high doses of heart failure medications. For stakeholders engagement, like I said, we conducted semi-structured qualitative study interviewing older adults with heart failure, and then we asked the questions, what they would think about their heart medications, what situation they would feel that is too much. And we refrained to use from using the intensity, because I got a feedback from the community scientists that the term is too confusing. So I had to change some of the verbatims according to their feedback. So these are the results, and we identified 7 themes in identifying the intensity from the patient's perspective. And then there are physical aspects, like they are having some side effect, and operational aspect, like they are having some problems with logistics and cost. And then the other part was the psychological aspect. They had a lot of emotional distress about medication use, not only with the burden, but with the geriatric syndromes like cognitive impairment and not being able to memorize or remembering the dose frequency schedules. One thing that I didn't expect, but we identified, is that the perception of intensity was heavily impacted by the patient-doctor relations. For those who actually took a lot of medications with high doses heart failure medications, their perception of intensity could be low if they had really good patient-doctor's relations, if they have a lot of trust. So that's something that I didn't expect, but we identified, and then it was one of the most common themes that occurred during our study. So based on my pilot study, we identified the most commonly used definition for heart failure medication intensity through scoping review. We realized that a very low percentage of older adults actually take high-intensity heart failure medications, and we assessed the older adults' perception intensity of heart failure medication, and we realized it's multifaceted. So based on this result, the next step is to assess which factors are actually associated with low or high intensity heart failure medications. And the next question that I really want to answer is whether the geriatric syndrome such as frailty would be associated with this intensity or different dosing intensity of heart failure medications. And the next question that I would like to answer is, should we modify the target dose of heart failure medication for older adults? Because as I can see, the target dose is becoming impractical for older adults. The next step I just dreamed about that I can identify optimal way to assess intensity of heart failure medications considering multifaceted patient factors that I've identified through the qualitative study. And I would like to acknowledge that none of this study was possible without support from USDEN Prescribing Research Network and my mentors, Dr. Holly Holmes, Dr. Raja Parasu, Dr. Dae Kim, Dr. Goyal, and Dr. Doble Abish in UT, and also my mentee, Nuza Amjad, who did most of the interview study. So thank you.
Are there any questions? I'll let you go for this one. Yeah, thank you. That was perfect. Dr. Holmes, Dr. Nayak, do you want to come up and present next?
I'll be first.
Okay. I wasn't sure if you're staggering or jointly presenting. All right. Let's see. You're welcome. That's you? Yes. Perfect. Love when technology works. Okay.
Good afternoon, everybody. Thank you so much to the USD Prescribing Research Network for funding this pilot study that we are just getting underway, and for supporting the work of so many of us here, including so many so many of us at UT, which I'm very proud, as you can tell. I want to acknowledge Jack Banks, who's in the back of the room here as well. He's sitting right by Dr. Amjad, who was just featured. So thank you for really driving this study. So I want to talk about this pilot that we are undertaking, priorities aligned deprescribing for persons living with dementia and their caregivers. So I don't need to tell this room, but as you know, people living with dementia take a lot of medications, and of course, depending on care setting, in the ambulatory setting, they could take an average of 8 daily medications compared to 3 for people without dementia. And that people living with dementia are usually overprescribed medications, and that can lead to excessively burdensome regimens for them, but not only them, but really their caregivers and the clinicians taking care of them. And we really wanted to look at that. How to reduce unnecessary medications in people living with dementia. We certainly need better interventions here, and we don't really know where the best targets always are. But we think that some of those targets don't begin with what matters most to those patients. So we really need to drive deprescribing in people living with dementia by what matters most to them. So patient priorities care, for those of you who may have not heard of it, it is a way to really look at what matters most. It is a process that looks at patients' goals and preferences and aligns the health priorities that they've identified with the care that they actually receive. And patient priorities care has demonstrated ability to reduce burdensome care. It makes sense that when you ask people what matters most and you really try to align the care with what matters most, it's likely that they are getting treatments that are not aligned and that those treatments could be reduced. So people who undergo the PPC process are more likely to have medications stopped. That was 52% versus 33% in a prior study, and more likely to have more unwanted medications stopped, and in this case, more likely psychotropic and cardiac meds, and a 5-point greater decrease in treatment burden as measured by the treatment burden questionnaire. So we wanted to ask in this pilot the following questions. How does patient priorities care facilitate deprescribing for people living with dementia? There has not been a widespread application of patient priorities care to people with dementia with a focus on deprescribing. And how are those blended priorities? So when you apply patient priorities care to persons living with dementia and their caregivers, which priorities are you looking at? How are those blended priorities between the patient and their caregiver, how are they interpreted and used by the clinician? And how do clinicians make deprescribing decisions based on aligning the blended health priorities of the patient and their caregiver? So we are undertaking a quasi-experimental study of people living with dementia and their caregivers who are receiving usual care compared to those undergoing patient priorities care process to identify their priorities, and having a visit with their primary care doc about aligning those medications and with their identified priorities. So I'm going to let Dr. Naik talk through the study.
To touch on a couple of themes that have been brought up earlier today. So this is an approach, a paradigm on how to do priorities-aligned treatment decisions or goal-defined care. And it's, and I should say this explicitly as Mary today would get on me if we called it a deprescribing intervention, because that's not really what we're trying to do. We're trying to optimize medications with people's priorities. So in some cases, we decrease meds. In some cases, we might have added a service or a care or even a medication if that's appropriate for the given priorities. So what's different in this project is, again, what Dr. Holmes said is involving a caregiver. And we haven't done, the PPC really starts with a conversation with a clinician, and we're pretty agnostic on who that clinician is. There's a structured training that we have developed, and it can be delivered by any number of people through a number of modalities. But the main focus is to identify a set of priorities, which starts with what matters most, contextualizes that into specific, realistic, actionable outcome goals, a set of care preferences, what people are willing and not willing to do to get to those outcomes, and then settling on a one thing to guide the clinician. And it's a structured note that we've developed that has been designed in a way that we think really affects clinician decision-making so that it is around identifying priorities. So in this case, we're applying this concept to a clinic. So this is not a pragmatic study in the general sense. It is more of a hybrid implementation effectiveness. So we are implementing it within a regular geriatrics clinic using the clinicians in their workflow. So that part of it is real world. However, it's not pragmatic in the sense that we want to actually drill down into how and why people make decisions and get into some more in-depth interviewing about that. So we are looking sort of mechanistically at the processes of how PPC might or might not be related to deprescribing, but doing it in a very embedded, practical sense. So that's kind of this study design. At a baseline, we're doing a set of assessments, again, confirming that they have cognitive impairment, looking at the medication lists, and then doing some of the same questionnaires that we've looked at before in terms of outcomes. Usual care group will be usual care, and it's going to be quasi-experimental because we really only do this in one clinic, so you can't completely blind the clinicians to the process. So we're basically running the control group first, doing normal control, usual care, then training the clinicians on how to do their portion of patient priorities care, and sort of doing that at the back end. And then, so we have that first visit with someone in the clinic who does the priorities identification, then giving those identified priorities to the clinicians and seeing what changes they make in care, and then following up with them afterwards to look both at changes in treatment as well as some questions around potentially harmful changes that might occur if you deprescribe an appropriate medication. So what we're trying to get at that's, we think, a little more novel in terms of the methods is some in-depth, two different types of in-depth qualitative interviewing. One is cognitive task analysis. So this is a methodology used by industrial organizational psychologists to really understand behavior, especially behavior of experts or anyone doing a systematic process. So we will interview the clinicians afterwards and really in depth ask them how they interpreted the priorities identification template, how they decided to make decisions to change a medication, either add or drop or increase or decrease a medication, and what were the factors that drove that. and to understand sort of those factors. And then we're going to do some classic qualitative interviewing with the patient and the caregiver to really understand, when the priorities were identified, whose priorities are we talking about? Is it the caregiver? Is it the patient? And the priorities process is really broken up into components. There's values, outcome goals, and care preferences. And so my hypothesis is that different members of that dyad drive different pieces of that, but this will be really an in-depth way of getting a better handle of what that is. So our current status, so it's taken us a little while to get this approved in the IRB and get it embedded within care and get the people trained, as you can imagine. And I did switch institutions in the interim as well, so that took some time. So we've recruited our clinicians, both the people identifying priorities and the clinicians who will do the alignment. And we now developed a protocol for identifying eligible patients within the scheduled patients for those clinicians. And we're beginning the process of now starting to start the active part of the intervention. That's all.
So at this time, I'd like to invite others. Thanks, that was a fantastic presentation by all of our awardees. Another round of applause for all of them. We have 15 minutes for a Q&A, so I think Dr. Campbell, you were going to start?
Yes, Noel Campbell, Indianapolis, Indiana. Question about this last project. One of the challenges we've had in the past, trying to understand, maybe not specifically task analysis, but the conversation, the interaction between patient and provider in the room has been, we can't put someone in there because then it feels not real. And there's preference against putting like a recorder in those sessions. So I'm curious about your experience in having success or your timeliness of your planned interviews in understanding the task analysis piece of your project.
So for this project, we're going to do it afterwards. We're going to have it, and you have to be mindful of busy clinicians' time. So ideally, I'd love to do it after each and every encounter, but that's probably not going to be practical. So we've decided to sort of batch them a little bit, 2 or 3 patients at a time, and we're just interviewing on the intervention arm, and then try to do a structured cognitive task analysis. That sense. We have another project where we've actually done tape recording, and we're starting that process and putting the tape recorder in the encounter and recording it. And you think that there'd be more resistance to this than otherwise. And at first, people are hesitant a little bit about it, but once you get past the consent, people often forget that the tape recorder is there, and they often have a normal encounter. So my suggestion is push through the initial resistance, get your approvals, get someone who's willing to play play ball, and just do it. That's my suggestion.
Any other questions from the audience? Well, I have some canned questions for our panelist here today. So unfortunately, Carmen Reyes wasn't able to join, so I will be conveying some of her questions from the stakeholder perspective and some of my own. So as we know, all of you have been awarded by the USD Prescribing Research Network. And how do you plan to take this the next step? With this work. So these were pilot awardees. So I know some of you are just starting, some of you are further along, but love to hear about your next steps to get this work and larger grants. So Dr. Hunt?
Sure, yeah. So I've been thinking about this. Actually, I just had a moment with Lauren Gerlach just before thinking about how we move this work forward. I think there's a lot of opportunities for thinking about other preventative and maintenance medications in hospice beyond anti-dementia medications. So thinking about things like cholesterol medications, blood pressure medications, and how do we think about getting patients, especially patients with dementia, which is my area of focus, off of these medications, or thinking about how they're making sure that the use of these medications is aligned with the patient's goals of care. So I think there's some opportunities for moving forward with that, and then using Medicare data as well as thinking about electronic healthcare records and have a little bit more granularity, and you can get a lot more detail around when these medications were actually stopped. And we're working, one of the stakeholders actually that's part of this group is a pharmacy benefits manager, and they have, they actually have different models of payment that they use for delivering hospice medications. So you could do a really neat study where you actually, like, you can test how the different packages affect the prescribing of those medications in hospice. So those are the kinds of things I'm thinking about right now.
Sure. So, initially we just wanted to do a kind of pragmatic intervention of, can we get doctors and patients to talk about opioid deprescribing? And like, in full honesty, we looked around and couldn't find good tools to help support those conversations, mainly deprescribing.org. I'm going to keep looking at Barb and just say that that's where I go for all my tools. And like, there's a poster over there from a mentee of mine that is that intervention for benzos. And we were like, let's do that for opioids, and found that because that data didn't exist, we needed to do this as a step. So our very clear next steps are trying to think about how we can develop those sorts of conversation aids and then test them out in the real world. I think particularly given that opioids are both quite high risk, but also I think it's not a clear this is a bad medication sort of deprescribing conversation. It is really one for informed decision making and not a sort of, I guess, like clinical decision. It's a conversation, and so we're really thinking about conversation aids in particular.
So I have a quick answer, long answer, and an official answer. So the quick answer is that I used the result of the pilot study for preliminary data for my career development award applications. So that's a quick answer. And the long answer is that after I identified the definition of heart failure medication intensity, I would like to see whether it has any kind of clinical implications. Because like I said, we only know the initial dose and target dose. In between, we don't know whether this dose would do clinical benefit like the other dose, and then we don't even know that whether if geriatric syndrome is incorporated in that equation, what's going to change in clinical outcome. So that's a kind of long answer. And an official answer is that it gave me a lot of confidence as a junior faculty who like to develop my career in research. So whenever I got this pilot grant, I was jumping like really crazy. And
We
it
love
gave
to
me
hear
a lot
that.
of confidence so that I can do more work and then
Yes.
I'm valuable. And then another unofficial answer is that Dr. Amjad over there, she was a fellow when I was doing the pilot grant, and then she helped me a lot, and she interviewed all these older adults, and then she also found her own inspiring niche that she would like to go from that experience. So I think it's a very unofficial but valuable result of my pilot
There's
grant.
many wins. Thank you.
Yes.
I would build on what Minji's saying since we get to work together. Our work also is part of our broader efforts toward an age-friendly health system and how we're thinking about medications and what matters most. And so for us, we really are working very hard to integrate this within our regular care, within our EMR, within the research that we're doing across different areas. And so we're finally getting a critical mass of people working in this area that can collaborate and be across inpatient and outpatient and transition settings. So for us, I think that this really helps us bring patient priorities care into our clinic, and it gives us some teeth to do that and to make that part of our standard of care. So I think next, we really have multiple different sources of support that we can tap into to help this continue. Secretly, of course, we work kind of in a fee-for-service life, and so I really would like for our work to eventually support regular integration of clinical pharmacists into the normal, everyday. I say normal, that means I'm saying it's not that the VA is abnormal, it's just that for the average primary care doctor who does not have access to a clinical pharmacist, life is very difficult. We would like to change that as well. So that's one of my secret hopes, is that we can justify having much more pharmacy presence.
Well, thank you, Dr. Holmes, for that. I'll pay you later. As a pharmacist here. Anything to add?
What I might say to any of the trainees in the room or really junior faculty is it's great to take pilot projects like this and use this for work you want to do. So I'm hopeful that Jack will be able to use some of the work he's doing in the data, for future projects and work that he might be interested in as well.
Fantastic. To the audience? With Dr. Helmer, I think you were next.
Thank you, and I have to say that they were fabulous and inspiring projects, and it's really great to see all this new deprescribing work getting off the ground. I've got a few questions because while I was sitting there, I thought of a few more. But firstly, Lauren, I really liked your work, and I was wondering if you were thinking about potentially using other drug classes as controls to understand your data better. So if people were look at, say, I don't know, deprescribing statins and proton pump inhibitors as sort of key examples, and see whether the issue is actually around whether people are thinking about deprescribing overall versus whether people are thinking about dementia medicines.
Yeah, and I don't know if I'd had that thought, but that is a really great idea.
You have to say that to visiting speaker. Thank you.
Take that. Yeah, no, I think that's true. I think the anti-dementia drugs might be actually really different because, people, and this is something that I've been trying to get at a little bit with the stakeholder group and qualitative interviews is, do these meds stand out? Do people remember the conversations about them? And I'm not actually getting that sense just from kind of qualitative elements, but it's I think people develop attachments to different medications for different reasons. So this one, but yeah, that's
It'll
great.
be interesting to tease out whether it's an issue around medication review overall or whether it's specific to these drugs. Thank you. And just while I'm here, Dr. Anderson, I just have to alert you to the fact that outside of North America, there is a fantastic evidence-based opioid deprescribing guideline and patient decision aid that you might want to adapt to as health service, which I can see it is quite different for a different population.
Yeah, I've since learned that there's, as usual, many countries ahead of the U.S. in terms of things. The one thing I think from the patient qualitative side that we haven't gotten to talk about is, and maybe I'm just not as aware in other countries, but the media kind of perception of the opioid epidemic and how that's resonated with older adults in the States feels unique, in part maybe because there's a lot of awareness actually of things like the CDC is trying to take away all my pain pills, is something we got back from patients that I'm wondering if there's some, as you said, adaptation to kind of the cultural context of the U.S. and just where the opioid epidemic is here, is one thing I think about when I read the work of folks in other places and learn from it.
Thank you. And look, I think we're seeing a different opioid epidemic in our nursing homes where buprenorphine is the new haloperidol. And people saying, oh, well, maybe they're in pain. Let's try buprenorphine. And I'm sure it's different in different contexts with different regulations, but worth having a look. And just one more from Enchant. Your work on heart failure was fabulous, and I have a PhD student doing some fairly similar work at the moment. I was just wondering, sort of thinking more broadly about, I guess, this full spectrum of translational research. Have you thought about what is best practice in frail older patients? What should we be targeting, and what sort of data can you use to inform that?
For translational research?
Well, fully thinking about sort of the pharmacokinetic and pharmacodynamic changes you might see and that kind of thing.
I never thought that, but it's really good idea. She really inspires me.
You've got to be nice to the visiting speaker.
I know. When I was listening to your talk, I was literally thinking about mice giving all these heart failure medications and then do ejection fraction, echocardiogram of the heart of the mouse.
We have done echoes on mice. I didn't talk about that. But
that
I actually
kind of
just
crossed
get
my
some frail
mind.
older people and give them drugs and measure their levels and see what happens to their echoes.
Yeah, that'd be great.
Thank you very much. I'll stop asking questions.
Thanks, Dr. Helmer. And for those who want to experience more of Dr. Holmes and Dr. Helmer and Dr. Korten, we'll be doing a session tomorrow from 2:45 to 3:45 on opiate deprescribing and prescribing. So the conversations will continue. I'll give it back to the
George,
audience.
can I make one comment?
Yes. Sure.
So, there's an optimal physiological answer to that question, right? But we're talking about multimorbid older adults who are, N of ones themselves. So if someone published an optimal dosing, I don't know that that's really what I want, right? So this is where I'm going to, sound like a broken record. We should identify individualized priorities and have that as the outcome to define, and then optimize the dosing of the medications to get to that optimal dose, rather than looking at a standard physiological number. That's, the answer I'd probably give.
And Minji, despite the fact that Anand just stuck a needle in our balloon, if you want to do that experiment, we could do it, no problem at all.
Oh, I can just go across the street.
You can go visit across the street.
It's very far. I wanted to ask you a question on your experience compared to what your data showed. So your data showed that the target doses were almost rarely attained in all your older people with heart failure. But I see it a little differently. I see the ones that go to the heart failure specialists, even if they're now wheelchair bound, now have a blood pressure of 84 systolic on their good days, still are all at target, and the heart failure specialist is very proud of it. The ones that go to the cardiologist, sorry, if anybody here is in a heart failure specialist,
There's a couple.
my condolences. Oh, and by the way, it's only beta 2 receptors in lymphocytes, not beta 1.
By the way, he's my mentor.
Yeah, that's okay, that's okay. If you screen those patients, that would be, the cardiologists do, I think what you saw, and probably you and I in clinic are on the side where, you know, it's so nice not to have to get up 7 times a day to pee, that maybe I can make some, I really think that's one of the things where if you could find like one more layer of nuance, or just taking what the data says and reflecting on what you see in clinic, it'd be so much of a cooler story to tell us all.
Yeah, thank you so much for the comment. So one of my career goals is to be in geriatric cardiology and infiltrating cardiology side as a geriatrician, and I do a lot of I do geriatric consult service focusing on the cardiology unit in the hospital, and then I'm very fortunate to be in UT because the cardiologists at UT are very geri friendly, and they want our presence in their unit because they know that it's not safe to give all these medications whenever their systolic blood pressure is 80, but they have this feeling of obligation they have to give because it's on the guideline, and then they believe the guideline is kind of Bible. So and then geriatricians, we are very nice, but we are also the bravest specialists who can advocate older adults based on what matters most to them. And then I show up to the unit and they said, it's okay to deprescribe these medications. And then they would like, oh, okay, you said it's okay, I'm gonna deprescribe it. So that's what they do. So I really appreciate your comment that we have to work more with the cardiologists and make a strong ally.
I want to share an anecdote about that. Thanks to Minji and our other faculty with cardiology. A cardiologist called me the other day in clinic and put me on speaker with their patient in front of them. They wanted to deprescribe the statin, and I said it was not appropriate to deprescribe the statin because it was a patient who had had an acute event. So I was talking the cardiologist out of stopping the statin. That's where we are at our institution. Yeah. Well, I know you're happy, but the point being that this is the conversation we're having with them, which is pretty amazing.
That's fantastic. And I'll take the last question from the audience.
Hi, it's me again. Steven Sapoyo, Swedish in Seattle. So I actually happen to be an addiction specialist who's now doing geriatrics, so the opioid deprescribing thing is speaking to me. I was curious also for the audience if anybody, because there are resources for having those conversations, it's very difficult conversations, and I actually piloted a kind of a motivational interviewing kind of themed discussion around opioid deprescribing, and you can see my poster 37. Wondering, are there resources out there that kind of incorporate motivational interviewing? Is that something you're planning on doing? Because you mentioned conversation guides, and I just imagine that would be a good mesh.
Happy to chat. Is probably my best response. One thing, getting to the stakeholder theme, one of the clinicians I work with closely is an addiction medicine trained, like our primary care director of our addiction medicine clinic, and was on an ARC, not research grant, but implementation grant that was trying to think about even just monitoring opioid use in older adults. And even from ARC, which was really trying to disseminate like best practices, it was really still in the realm of let's make sure we're doing urine drug toxes and signing opioid pain contracts. Also, what came up in our conversations with patients, we would ask them, do you talk about opioids with your doctor? And they'd say, well, I signed some contract every year. Does that count as talking? And so we felt like we were so far away from even like talking, like not even getting to motivational interviewing or like advanced techniques. Like it felt like sometimes patients would just say, I'm on this and I hope no one bothers me, because the only time they do bother me is when somebody tries to like interrupt everything, and my primary care doctor just doesn't ever bring it up because we're too busy with other things. And so I think motivational interviewing, from my perspective, is the place to go. It just felt like in the real world we were so far from even getting it high enough on the agenda, which I think is particularly in general primary care always the issue, right, for any topic.
Fantastic. Well, just to keep us on track and on time, I want to thank each and every one of you for your time, your expertise, and your involvement. And I'm going to let a round of applause here. And this time, Dr. Steinman, if you want to make announcements.
Thank you. What a fabulous session. So next we have our afternoon poster session. More of the same in the morning. See some great science. Sugary and caffeinated stuff in the back. And have a chance to talk. We will, our next podium-based session will be at 3:30, whereby we'll have sort of an encore performance from last year from Kristen Zimmerman and Amy Linsky about updates in deep prescribing research. In previous years, we've had games, we've had jokes, and so I kind of can't wait to see what they'll have this year. So thanks, everyone. We'll see you in talking.
Good work, yeah. I'm really intrigued with the different pairs and like the natural experiment that's going to come out of
I
that.
know. I think I just came up in the ROA.
I was just going to say, and we did with our, because we did a large data set, we did our comparator was like stats.
Oh, yeah.
Because there's like not as much emotional connection. I don't know if it's the best based like comparator group, but to Sarah's.
Tell me more.
So we did a policy piece just recently looking at large claims data sets, looking at the influence of the antipsychotic reduction initiative.
Oh, okay,
And so basically, and we had to have a comparator group to see. But when we talk about mental health medicines, there's a lot of different associations, both from a regulatory as well as a patient family perspective.
Right.
So
Yeah, it's super interesting. I thought that was a really great suggestion. I don't know if people have that same sort of attachment to the anti-dementia money, especially when they're in like these advanced stages.
It's interesting though. I went to a program. It was very disturbing, and so I was asking about the education. It was actually at AMDA, and it was a well-known geriatrician medical director, but he was talking about pushing multiple cholinesterase inhibitors in patients in advanced disease to avoid the use of antipsychotics.
Yeah, well, that's come up too. It's like it's the lesser of evils.
Yes.
Basically, like I've heard of people starting them in hospice, which is insane.
Yes. Well, and then multiple, and I was like, "You're joking." He's like, "A little bit of this," and I'm like, "They're the same."
And the neurologist is so interesting because like I couldn't believe how many were on it prior to hospice, like 50%, and that's why we've been pretty worried about
aducanumab
and the MABs or whatever they're called.
Yeah, the monoclonal antibodies. Yeah.
Because like if 50% of people are taking them before they go on hospital, it's like a lot. It's a lot of people. That's what they're banking on. It's like once they start these medications, it's gonna be like.
But they're so indicated for like early on.
They are, but then it's like when do you stop?
Well, I think there's extension trials going on right now, and I think the thing is, I don't know. I think we just don't know.
Right.
Once a disease progresses beyond a certain. I think once a disease progresses beyond a certain point. Because I haven't drank the Kool-Aid that this is a disease modifying agent. I think there's still slope in that decline. So so I think it'll be
just like how many of these people are going to be on those drugs in like the year before they die?
Yeah. Well, I hope they're not still on the drug.
We'll see.
But it'll be interesting with compelling like other indications of why they're on hospice though. Right?
Yeah, right. Like all the people who are in hospice for something else.
Yes.
Yeah. So the stakeholders committee that we met the other day, and they were like, if I have somebody who's coming on for heart failure or whatever, like I may keep them on. I may actually keep them on. An anti-dementia drug because they might be in hospice for a year. And that's like this is still. I don't know. It's like these drugs to me have such limited benefit to begin with. But
and that would be an interesting angle to this as well, right? Because what is the primary diagnosis, and then what is the concomitant use? Right.
Yeah. It was kind of interesting for me. You didn't actually see a difference really between people who were like it was across the board same for the people who were on for primary. Like I kind of would have thought people are on for primary diagnosis when it's probably less.
Yes, exactly.
But that's not really what we're seeing.
Okay.
So and then I
I mean, it's just also, the payer staff is really interesting. It's like
So do most of
85%.
them cover? I was kind of surprised that like most of them still cover it because there's like been
Part D covers, yeah.
Right.
So the hospice agency isn't paying for it.
Right.
So
yeah.
they
So
don't
they're not
care.
at risk.
They don't care. They're just like, what can you,
And they're pretty
Medicare is like, no hospices, you have to pay for this, and they just don't.
Right.
And no, there's no like consequences right now.
No, there isn't. Yeah.
So this pharmacy medicine manager, he's like, we have these different payment models. So like, one is they do like bundled.
Yes.
So you get like a per diem, and then you can get like these medications, or you can do like pay for each medication separately. The hospice pays for each medication separately.
Yeah.
And he's like, we see differences in like what medications continue and don't.
I could see that. Yeah.
I think I just came up with like the R1 here and now, right now, for how we continue this work.
Yes. Oh my God, absolutely covering that throughout. So
Mike is a mentor on this project.
Fantastic. Good. Well, it's interesting work.
Yeah, thanks. Yeah, likewise. Sounds like you're doing some. The policy stuff is really interesting.
Well, I think, at the end of the day,
it's so hard to change things like without that.
Exactly.
You know?
No.
It's like somebody made that comment earlier. It's like
with the antipsychotics.
Yeah. It was like until the regulations came on, it was just like
the payer model, that's what you're going to exploit.
Yeah.
Because I think that makes it very innovative and sustainable, right? And I think, and that's been a confusing point. I remember, and these are cheaper medicines, so I don't think they're flying, but it is
not that cheap.
No,
they're like
I
was asking, it's like $200 to $400 a month, so it's actually like
the patch is expensive, and I find the combination is expensive.
Yeah.
So